session and ask. So the moderator will ask for the questions of whatever you are requesting. So we don't want to waste your time. That is the main idea of this, and we just want to make this free, open access emergency medicine available for everybody online on YouTube. After this class, this can be accessed on YouTube. So we'll try to upload it, but we don't know if we can do it today or in 1 week time. But surely we'll upload all the episodes of this series. So today we're going to deal with the first episode, which is ATLS 11th edition updates. I'm Dr. Nayan, and I'm an assistant professor of emergency medicine at Apollo Medical College, Hyderabad. We're going to go ahead with the first part. So let's begin with thinking about the 10th edition of ATLS. We all remember reading it, and it was very easy to understand, and it was very, well written. But here, the 11th edition is a total entirely different thing. It is divided into 3 units. The first unit is basically the entire ATLS 10th edition. So the first unit deals with the entire 10th edition, and the first unit is called Evaluation, Management, and Resuscitation of the Injured Patient. And as you all know, it is XABCDE. So the first chapter is initial assessment, and they have given a very good diagram here of initial assessment and the components of initial assessment. And the class, how I'm going to plan this is that I'm going to explain the 10th edition details, what was there in 10th edition and what is new in the 11th edition. That's how we will compare and we will go forward in this entire discussion. So now in this, the 10th edition also told about the components of initial assessment as the primary survey, the adjuncts to primary survey, re-evaluation, secondary survey with the adjuncts, determination for need for transfer, and definitive care. But this new diagram is emphasizing on the components. And in the 10th edition, the 10th edition dealt with the initial 10-second assessment, which is the looking at the 10-second assessment of patient ABCDE. But people started doing that as a routine thing. It does not mean we have to do it routine. It only mentioned the fast usability of this 10-second assessment. So here in 11th edition, they have removed it altogether. They have removed that mention of the initial 10-second assessment, and they have asked us to use direct XABCDE approach. And in the 10th edition, it was mentioned that they're only writing it sequentially to emphasize what is important and what kills first. But people have decided to use only as a sequence approach. They wanted to decrease this misconception, and they have now made it as a dynamic trauma evaluation and simultaneous identification and management. So EFAST previously was used as an adjunctive. Now it is an integral part of diagnosis in circulation and thoracic trauma assessment. And the role of the team leader is more prominently defined now. And second chapter, here, this is a new chapter, and this is focusing on effective trauma team communication and leadership, because they felt that a maximum of the human errors in trauma management could be avoided by good communication. So that's why they have brought this concept, and they have made the principles of crew resource management and pre-briefing, task clarity, role assignment. So all of these are emphasized to avoid errors, and they've given this debrief tool also. Chapter 3 is control of exsanguinating hemorrhage. So they have mentioned this term exsanguinating hemorrhage specifically instead of mentioning massive hemorrhage or life-threatening hemorrhage, as they have mentioned in the 10th edition. 10th edition also talks about CABCDA approach, which is control of life-threatening hemorrhage before airways, all that. Right, but now they are talking about XABCD because the simple thing is they wanted to bring in the X factor. So they wanted to emphasize that this is going to kill the patient. So that's why this was brought in. And here they have made it as a very elaborate and a very good explained chapter. They are explaining the use of tranexamic acid very well, because previously it was only like 2-3 lines, but now they are writing the pharmacology of this drug and the utility of this drug. And here their use of tourniquet, hemostatic gauze, junctional tourniquets were all again re-emphasized. It was there in 10th edition, but it was added in the appendices. Now it is in the third chapter with good emphasis. And the whole blood transfusion is also mentioned here. So Ribova is again mentioned here, but we all remember reading Ribova in the 10th edition also, but there's no Ribova in 10th edition. There was absolutely no mention of Ribova. Now they have mentioned Ribova in the 11th edition. And the airway assessment and management is the next chapter. They, in the airway assessment, previously, there all techniques were there, all the methods of airways, securing airway were there. And there was minimal decision-making framework and the minimal discussion on the video laryngoscopy. In the 11th edition, the airway chapter has undergone significant modernization and it has taken a structured approach to anticipating a difficult airway. So they have taken a large part of this from the Rosen's textbook, I feel. So they have taken the concept of awake intubation, failed airway, and video laryngoscopy use. So they have also considered the human factors for failed airways. And this diagram explains it very well. So the multimodal concept of difficult airway is anatomy, the environment where you are intubating, the physiology of the patient, and the injury which the patient is presenting with. All of these are attributing to difficult airway. So they have integrated all of this and they have taken the difficult airway algorithm from Rosen's and explained it very well. What is the difficult airway, what is the failed airway, and when to proceed to the surgical airway. It was there previously as an algorithm, but it was not very well explained. Now it is very clear, and the rapid sequence intubation drugs are also very well explained now. And there is also a post intubation checklist which is given. So all of the post intubation management, everything is very well explained in this chapter. So breathing and ventilation chapter. Previously, this was dealt as a chapter on thoracic trauma after shock. Now here it is an entirely new chapter on breathing and ventilation. The previous chapter dealt with life-threatening injuries, chest injuries, and potentially life-threatening chest injuries, the big six, all that. Now they're different. This chapter deals about integrating focus in diagnosing the chest injuries, and they have clearly given the landmarks of the anatomical landmarks of the chest. So all of these are now explained very well. They have emphasized on the threshold for needle thoracostomy. But here I've seen a few posts where they say that the 11th edition is asking us to put the needle in the second intercostal space rather than fifth intercostal. That is a misconception. They have not mentioned anything like that. In the 10th and 11th edition, both the editions, they are saying the the site for needle thoracostomy is both second intercostal space in the midclavicular line and the fifth intercostal space in the anterior axillary line. Both are there. Both can be taken. There is no preference. And in pediatrics, it is second intercostal space with the clavicular line. So this is again given clearly in the 11th edition. They are emphasized on the excessive oxygenation part, hyperoxia in TBI patients. All of these is given in great detail. Now coming to the next chapter, circulation and resuscitation. The 10th edition taught about the classification of hemorrhagic shock as a 4-class model and recommended initial bolus of 1 liter warm crystalloid fluids, 500 to 1 liter, 500 ml to 1 liter. So before this 10th edition, there was 1 liter to 2 liters. So they have come down from that to 1 liter. Now they have totally removed this 1 liter or anything of initial bolus has been removed in patients with unstable hemodynamics. So here it has mentioned for early control of bleeding previously. But the thing is, this 4-class model of hemorrhagic shock was not a very well accepted model. Even in 2021, I've seen this review article, which even I have felt the same. So I've just mentioned it here. In JETS, it was published. This review article tells us that this very rigid classification should not be there and it should be changed. So that's why in 11th edition, they have kept a dynamic physiology guided resuscitation, and I will show you the difference. So this is the previous classification. So in this classification, there is you can just observe one thing is approximate blood loss. This approximate blood loss is very difficult to identify in the trauma patient. How do we know how much the patient lost? That is one thing. And next thing, they have another thing is urine output and GCS. So these three you have to see. Now in the new classification, they have removed that. Instead of GCS, they have kept just briefly level of consciousness. So you can use ABPU scale for this level of consciousness. And also urine output was removed because we cannot sit down for 1 hour and measure the urine output in a hemorrhagic shock patient in ER. So they have just written it as a response to resuscitation. And so this is more dynamic and physiology oriented. And we have all discussed about the early blood product administration and emphasizing on whole blood. So we all now emphasize that RH negative, O negative, or RH negative blood is for pregnants only, and all the adults get RH positive blood, O positive blood, and also the AB positive can be given for FFP. So that's something they have mentioned. So this just wanted to see the pelvic fracture algorithm. Here they have mentioned Ribova. So the disability part, chapter 7. Here in the 10th edition, they have mentioned about the GCS, ABPU score, GCSP score, all of that were there. Here the same thing, but they have added spine trauma in the same chapter as the disability, and head and spine both are simultaneously dealt, because people have forgotten the importance of spine trauma, and maybe they felt that the spine trauma is being missed quite often because it's not given emphasis with as equal to the head trauma. So that's why they have made both of them in the same chapter, and they've added the 2020 brain trauma foundation guidelines also. And they've given very clear guidelines on managing the raised ICP, head end elevation, mannitol, and they compared the hyperosmolar agents, which was not there previously. So there is no winner in this, but if there is hemodynamic instability, if the patient is in shock, so they advise to avoid mannitol. So the new term, which is critical neuro worsening, was added, and there is a mention of optic nerve sheath diameter for patients in raised ICP in this. And there is early neurosurgical consultation and adaptations of pediatric GCS is mentioned. So that's there. Next chapter is exposure and trauma. Exposure and environmental threats. In the 10th edition, they were all there. It was dealt in the subsection of primary survey. Minimal discussion of active rewarming techniques, and there was no emphasis on warming devices or blankets. Here, they're talking about this as a new chapter, bringing it into hypothermia prevention. They're emphasizing this deadly trauma triad or lethal triad of trauma. First, in the 10th edition, this triad was only mentioned in the circulation part, in the shock part. So now they are also mentioning this triad in the hypothermia part. Obviously, because hypothermia is an integral part of it, and they want us to remember this while dealing with hypothermia. So apart from that, there is also forced air warmers, and all of that is mentioned. Next chapter, thermal injuries. In the 10th edition, the modified Parkland formula, escherotomy, inhalational injury, transfer criteria, all of them are there. Same thing is retained, but there is individual fluid titration mentioned, and early airway evaluation in inhalational injury. There is prioritization of rapid referrals to burn centers and burn triage during mass casualties. So this new table gives us a easy approach to remembering all the formulas of different types of burns in adults and pediatrics. In chapter 10, musculoskeletal trauma, 10th edition described limb assessment, splinting, stabilization, open fracture management, and followed the 6 Ps for neurovascular evaluation. The 11th edition builds upon this by including ultrasound used for compartment syndrome diagnosis, fracture detection. The regional nerve block has no update. So block on arrival or anything, there is no update on that. There's only one line mentioned about this in both the editions, that before giving a regional nerve block for pain management, document the neurovascular assessment of the patient. So that's what is mentioned in both. The pelvic binder use, no change. Emphasis on early realignment and immobilization. Emphasis on tourniquet use in catastrophic bleeding is emphasized here, because it is also used as a core skill now. So in ATLS 11th, it is given as a core skill. Tourniquet application and different types of tourniquets. Trauma, pediatric trauma, there's no change at all. So the same Broslo tape, same thing of structured recommendation on child protection, early recognition of compensated shock, glucose monitoring, normothermia. So all of these are there. In the older adult, there's some changes here because the geriatric is an upcoming branch. Geriatrics is very neglected part of emergency care. So trauma in older adult, in the 10th edition, it noted very briefly about a presentation being atypical in elder patients and mentioned about the comorbidities, beta blocker, masking tachycardia, medication effects, all of that. In the 11th, it expanded and modernized this into something called as a frailty assessment as a prognostic indicator is added. The risk of under triage for elders is added, and the concept of ageism, even with normal ageism, is also added. So polypharmacy issues and reversal of anticoagulants were there already. Slower recovery and greater risk of post-trauma complications. There's a stronger emphasis on lower thresholds for CT and trauma team activation, and there is discussion on goals of care. Trauma in pregnant patient. In the 10th edition, we have seen there is a uteroplacental perfusion, fetal monitoring, perimortem C-section, and recommended left lateral tilt. All of that we have seen. And in the 10th edition, I felt this table 12.4, trauma in the obstetrical patient, a bedside tool, to be very useful. The 10th edition had this table, but in the 11th edition, they removed this table. We don't know why, but that was very useful. And the 10th edition also had a dosing error. Here, I thought it was only in my book, but I've checked it. So this RH negative, the RHIG ampule, is given as 300 grams, but it is in fact 300 micrograms. So this was the error, which was rectified in the 11th edition. So it is re-emphasizing the same mother first principle. Stabilizing the mother helps the fetus. So this clear indication for timing. In the 10th edition also, it was given as 4 to 5 minutes of time for resuscitative hysterectomy. It's the same, but here they're saying 5 minutes. No major difference. And clarifies the RH immunoglobulin administration guidelines. And also, CT is not contraindicated if it is absolutely needed. So that's what they are validating now. So you can read up on it clearly. The chapter 14, secondary survey. 10th edition secondary survey was covered within other chapters. So each trauma, like thoracic trauma, abdominal trauma, everyone had a secondary survey. Here, at the end of primary survey chapter, there was there. Now, it is a formalized framework. So it has a brief checklist. Right. Now, it has a very detailed approach like the ITLS guidelines, like head to toe examination, so the heat and all that. So posterior inspection log roll is also again emphasized. They mention about modified log roll, but they don't mention how to do that modified log roll. So I don't know what is this modified log roll. So that's chapter 15 is transfer to definitive care. 10th edition highlighted the principles of stabilization before transfer, airway protection and all. And here in the 11th edition, they've given the standard handoff protocol as SXABCDE bar. So the S bar is mentioned as SXABCDE bar. This is something changed. Apart from that, all the team coordination, communication with the receiving facility, documentation, all remain the same. So much difference. So this is the section 2, which is trauma systems and patient-centered care. Here they have trauma systems, the add-on matrix, the triage and disaster management. So the triage and disaster management is in fact cut short. They have reduced it very much, and they have only dealt with the mass casualty events. Whereas in the 10th edition, it was very well explaining the CBRNE threats and all the different disasters. So I feel very bad about that because they have cut it short. So injury prevention is there. Trauma informed care, social determinants. This is the public health aspect of trauma. Communicating serious news in the acute trauma setting. So they're all there at some or other part of ATLS in the 10th edition. The thorax trauma, penetrating trauma. They're all different chapters now. Penetrating trauma is a different chapter. Ocular trauma was there in the 10th edition. Like I've mentioned, the 10th edition appendices in the below. You can see that. And tactical combat casualty care is also there in the 10th edition. It was mentioned in the Appendix C. So now also they have given it as a separate chapter. There is no big addition to this. There's no change. The same March protocols are followed. Apart from that, the first unit has major changes. I think that's the important thing for us to understand. And as we keep reading this book more and more, maybe we will understand. So this is Dr. James K. Steiner. We all know him as the founder of ATLS. So he has passed away on January 22nd, 2024, recent last year. So just wanted to commemorate his legacy. And our next class is on disaster preparedness by Dr. Shirath Chandra, a very good friend. So it will be on 28th, next Saturday. We'll be talking about the disaster preparedness in the ER. Our concept is that we want to talk about the uh, ongoing issues in the world, which is ongoing wars and disasters. So that's why we are focusing on those topics this month. So thank you very much. I will just open this session for the moderator. If anybody has any doubts, just leave them in the chat. I think, yeah.
Nayan, you can take questions directly from the chat box.
Yeah. So, yeah, I'm just reading the chat box. I think my wife is commenting very informative, must watch. Okay. Leukodepleted blood, warm fluids, preferably 39 degrees. Blood transfusion, warm or as it is from. Yeah, so uh, warm blood transfusion, warm blood should be ideally given. So we have to bring it down from the no mention of diamond of death. No, I have not seen it. Diamond triad still, yeah. Still triad of death is there. There's no diamond of death, and blood transfusion should be warmed blood, not as warmed as the fluids, but room temperature. So I think see that 11th edition is more concept oriented, and it is more like our Tintinelli textbook. So people who have read Tintinelli, who are following Tintinelli, will feel that there is no much difference, and they feel that all of these are familiar. So that's something good for us. And apart from that, so whole blood is preferable than transfusing all blood products separately. No, in the MTP protocol in this edition, they have mentioned about the blood products only, and they have clearly mentioned about 1:1:1. So there is whole blood as a concept, and they are asking you can go ahead and use it, but they're not saying which is better. So blood products are still there. Can you share all news updates in a single slide? I will share the slide PPTs to you. So this is basically expected as a exam question for the ongoing students. So I will share it as the PPT I will share to everybody. And the initial assessment can be visual impression only and probably not protocolized like ABCDE, as the latter are components of primary survey. Sanjeev sir, I say. Okay. Sir, protocolized and latter are components of primary survey. Your take on initial assessment. It has always been confusing. We have already attended the 10th edition a few months ago and got the 11th edition training. See, 10th edition will be valid for 2 years. So maybe I don't think you should take that. Apart from that, any subject questions? Sanjeev sir, I didn't get this question, sir. Take on initial assessment. It has been confusing.
Hi,
Dr.
Nayan.
Lokeza, can you just, sir, hi, sir.
And I just wanted to mention, as you mentioned in earlier slides about the initial assessment. Actually, whenever we
Yes, sir.
do initial assessment in the form of A, B, C, D, and E, and
Sir.
we waste some crucial time in the beginning. So initial impression
Yes, sir.
and suggested in ACLS or PALS book, the initial assessment should be visual assessment only. While you approach the patient on trolley, you make your initial impression that whether this patient is very sick, or you trash on the basis of severity, on basis of your initial impression, visual impression only. In primary assessment,
Yes, sir. Yes.
we still look for protocolized like A, B, C, D, E, whether we look for the individual components, and we also try to manage the individual derangements one by one.
Yes, sir. Yes, sir. So the same in 10th edition, they were mentioning the initial 10 seconds assessment, visual assessment. But here in the 11th edition, they have removed that 10-second visual assessment, which we all follow actually by asking the name of the patient and placing the hand on the radial artery and looking at the respiratory effort, all of that. It is removed in the 11th edition. So I don't know why they did that, but it was very useful for the 10-second visual assessment. And the later they have also emphasized that ABCDE should not be simultaneously, I mean, should not be sequentially approached one after the other, but it should be simultaneously approached as a team. So that's why they have mentioned the clear roles of team assignment, role assignment, and all that before initial assessment of the patient. So they want us to gather the team, give assignments, give each team member appropriate role. So crew resource management is something they have said, and they want us to have a good team. So that's what it means, sir.
Okay.
Okay, sir. Can you please share new trial or update in upcoming classes? Yeah, we will do this in the coming sessions. Thank you. I think we can finish this class if all of the thing is done.
Yes, it's already half an hour,
Thank you,
so I
Sanjeev, sir.
think it's yes.
Yeah, thank you, Sanjeev sir, for coming and giving your valuable feedback. And thank you all for joining. So please log in for the next week's class. Thank you. Take care. Bye.
Thank you, Dr. Nayan. Thank you, everyone.